เราจะขีดเลย
พยายามไม่ต้องหลบทางโน้นใช่ไหมไม่
แต่เมื่อเช้าไม่เป็นนะจ๊ะ
เมื่อเช้ามีพักหนึ่งเป็นอยู่นิดนึง
เป็นเหมือนกันเหรอ
เป็นนิดนึงแล้วมันต้องพยายามหลบหน่อย
จะลองเปิดไมค์ได้
โอเค ฮัลโหล ฮัลโหล ไม่ค่อยมีเสียง ฮัลโหล 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 โอเค Okay. Good afternoon. Hope you'll stay awake, huh? ขอบคุณมากค่ะ โอเคแล้วฟังโอเคโอเค
การใช้นี้ได้แล้ว
All right, so this afternoon will be transesophageal echo. So the talk will include the outline will be competency of the transesophageal echo, indication, contraindication, preparation, probe insertion, patient preparation, and standard of the GE views, and hopefully we have some time for cases. So before you go to transesophageal echo, you need to have some knowledge, basic cognitive skills, and competence in echo, as I think you already go through the transthoracic echo already. Is that right? And then you need to have some background in the knowing all the general echo the diagnostic problem, the knowledge. That's very important. And for doing TE, you need to have a good basic understanding the difference of each clinical cases, what you need to know from your, if you want to do the TE, you need to know what you want to get to know. You have to understand about the sedation, conscious sedation, and the anatomy of the heart, and the technique, device, or under the probe, or the knob that you need to know about your machine. Also, you have to have the technical skills of the, if going for TE, have a conscious sedation, have to know how to pass the probe. For you, you don't know, have to know, but you need to know the person who's going to pass the probe, what he should encounter, and what you should look for while he's doing that. And the operating room, because TE will do in the operating room or the cath lab. And quantification of anatomy and disease of the valve leaking, stenosis, or those type of things, and how to get to the report. Generally, for TE, we need cases that you need to perform. The doctor who do the TE have to be trained for that. And basic TE, advanced TE, and then intraoperative TE, all those, they have to have a basic knowledge, and then they have to have probation period of performing the procedure, and then how to maintenance, how many cases you need to maintenance to keep on doing. The more high level you are, the more cases that you need to have experience. So for what's the role of the sonographer? We are integral part of we are in a team, so you have to support the doctor or the person who do TE, and then you should know what they're doing, and should know the person who doing it. You don't want to go to court with that person, is that right? If he do something go wrong, because the whole team will be problem. So we have to look after one another, work as a team. And if someone miss something, you have to set trigger and then alarm that, let's say the patient blood pressure drop or something bleeding here, or that you need to speak up and let the team know. And also as a technical part, you need to help optimize the image, or adjust the gain, control, color, or the machine setting, and how to crop from 2D to 3D during the T exam. So, but the sonographer, we don't expect. The ASE's American Society Echo do not advocate sonographer to perform TE intubation or manipulation of the probe, okay? So general indication for transesophageal echo is to look at, evaluate the cardiac structure and function in case that the transesophageal echo is non-diagnostic. I cannot see well because TE, you can see the image much better. For example, you look for the prosthetic valve, look for IE, look for valve, valve abscess, or those details, or patient on ventilator, critical care, was intubated, or patient in OR, or this type of patient has chest injury that you cannot do transthoracic. So there has to be an indication to do the TE. And during intraoperatively, usually we'll do for patient when the open heart surgery, valve repair, valve replacement, or those TE will help her to evaluate during procedure and post. And to guide nowadays the transcatheter procedure, so many of those. So TE will help guide them, the procedure of the transcatheter or the device thing and critical patient. So this important, this one you need to know, indication for transesophageal echo will be one of the exam question. So approach for transesophageal echo. To the probe size, we have to select the probe size. Baby, you need a small size, or Adult might be bigger size. So generally, there's a micro multiplane probe for people more than 2.5 kilogram is for pediatric or for baby, and then for those for 3 to 3.5. But usually for baby, majority of time you don't need to do the TE because the image is very good for baby. But that has to indication sometimes they are either they were intubated or they have chest wall problem or those type of things. Adult we do quite often, and usually the problem we need to monitor closely, and then ideally we would like to let the patient do without suffering. So we give an IV sedation. But the problem is when with the IV sedation, our country economy, or the money, or the room, or the expense for the IV sedation room, recovery room, or those. So most of the government hospital we do without sedation. So only we give a local anesthesia, lidocaine, spray, or this I'll go to detail later. Because if for the IV sedation, then usually anesthesiologist, we can request anesthesiologist to come and help. And you have to monitor closely, everything has to be there. And after procedure done, patients still need to be monitored for 1 or 2 hours after that. So we have the problem with the capability of the room and the equipment, everything. So mostly we do with the conscious patient conscious, except we give a numb medication or lidocaine to do that. And then besides that, when patient awake, they can swallow. With the swallow, they help bring the tube down more smoothly. So the step involved the probe care. After the doctor do the procedure, remove the probe, you wipe, use a tissue or whatever, or the gauze wipe, so you can remove the debris or the material that come out, so you can clean easier. And then transport. The probe should be transported in the box that for putting the probe, because the one probe, you know how much it costs. TE probe. Let you guess. เท่าไหร่นะ 1 million. 1 million baht. So it's quite expensive because that probe, it's thermal sensitive, and then the transducer, that's a part that you have to be very careful. 1 million. So if something go on, then a million's gone. And then cleaning, usually there's a solution that is combined that you will rinse and remove the enzymatic cleaner of the probe, okay, and then you hang dry, manual hang dry. And in the past there's requirement, but now they say that the company say they don't need to. We have to check, make sure there's no electrical leakage, the test about that, and that it need to be disinfected, rinse nicely, and dry it and store. And then if transport, we transport the protective container. So after inspect, before you do it, we inspect the probe, make sure that no tear, no nothing, okay, everything good, and then check the knob, make sure it's not locked. You see the probe here, make sure it's not locked, and then the patient will lie on the side, left lateral decubitus, flexion neck, and then we need to get the oral suction, everything ready, pulse oximeter, and then CPR equipment and medication reverse. If you're going to sedate the patient, we'll put through here, okay? For the probe insertion, after the patient, we need to check their teeth that have any denture. We'll take it out, and then we put the mouth guard. This is the mouth guard. Put the mouth guard before we insert the TE probe. The mouth guard will protect the probe too. The patient won't bite 1 million baht gone if they buy through that TE probe. Okay, the mouth guard put in first before we put the TE in there. And the patient will be asked to swallow. And then, as I say, the knob should not be locked and in neutral position. And then maybe a little bit anti-flex. And then you pass that through the mouth. And as the patient swallow, then you advance the probe down along this. So the most sensitive area is this area, because the patient will cough, and then so you have to numb, make sure it's a spray. Usually technician will be the one who spray, give the lidocaine or this, and then we have a lubricant before apply, put the probe, the lubricant, the gel, and then the mix with lidocaine, and then you numb the patient on the way here. Advanced, usually we'll see that about 30 to 35 centimeter. So sometimes some patients very sensitive. They just see the probe, they're up already. Cough, they're up. No matter what, in those cases, then we might need to IV sedation to calm them down and put this one in. So the mouth block, her mouth guard should be in place. Okay, there's the mouth guard. And then you put your probe through this. And then once the mouth guard is here, it's safe for you to use a finger, try to guide, make sure that the tongue, you not go under the tongue, you have to be above to go down. Okay, and then if so difficult cases, then we might need laryngoscope. This is a laryngoscope with a video, so can look where we pass through. Okay, so sometimes we need to use our finger to depress the tongue down. You see, on this side, you have to make sure you're over here and not go, when you go down straight, not go twist to either side of the tongue. And if you're not doing right, you can cause bleeding, hematoma, petechial, or even intramural or mucosal laceration. So it's very important to do. And then I always tell my fellows that no resistance. When you put that, the patient swallow, it goes smoothly along. If they're resistant, you need to stop. Okay. And if the first move, you get down nicely. If you have to go second or third, that's difficult. Patient already afraid, already phobia already. So minimize unnecessary manipulation and try to keep in neutral position and mildly anti-flex and adjust it and go down. Okay, let's see. This is the probe. Okay, so many different size. We put in a neutral. So as I say, you have to, before you do that, you need to ask the patient about the history, any problem, patient had any surgery on the esophagus, any ulcer, varices, alcoholic drinking, any bleeding before having irradiation in that area or this. So you know that you need to know the absolute contraindication or relative contraindication when you should not put the probe, okay? So the possible site, injury site, oral, you can lacerate the lung or denture, chip the teeth or those type of things. And then when you put in here the oropharynx, you can lacerate or perforate. And then you pull down, advance down further in the esophagus. Again, you can have lacerate perforation or causing false tract if you push in and can cause bleeding. And we're going down to the stomach. Again, the same problem. You can trauma all the way from the mouth to down here, or has been reported, okay? So patient have a tear, malleolus tear, then have pain after the procedure, and then laceration, hemorrhage, or this, or even case had been reported, even splenic laceration. I don't know how to do that, but if you force through, that will be a problem. Okay, complication, it can be, overall complication can be for the diagnostic TE 0.18 to 2.8%, intraoperative 0.2%, and even patient can die if you are not doing careful. It's a semi-invasive type procedure. There's morbidity, mortality too. Perforation, arrhythmia, tracheal intubation, laryngospasm, bronchospasm, dysphagia, or this hoarseness, lip injury, or has been reported. So when the probe go in, have to go straight. Sometimes if you turn to a side, it might go into the preformed sinus on one side, and you keep pushing, that'd be more problem. Or too much anti-flex, then you see it won't go in, and then you keep pushing, you can cause problem for false track there. And in the stomach, same thing too. Okay, you turn around. So there are many maneuvers. So as I always tell the first, no resistance when you go in. If there's resistance, you need to stop. It should go smoothly, no resistance. So the absolute contraindication, if patient had perforated viscous before, no. If esophageal stricture, esophageal tumor, perforation, laceration, diverticulum, active GI bleeding, those are absolute contraindication. Relative contraindication for those who had radiation done before, surgery done before, recent GI bleeding, Barrett esophagitis, dysphagia, restriction of neck fracture. Some people cannot bend the neck, or symptomatic hiatal hernia, varices, coagulopathy, those who have a PTT, prolonged or low platelet count, or active esophagitis, or peptic ulcer active. Those are a relative contraindication. So how to prep the patient? They need to NPO at least 6 hours before, because when you put it the up, if you just eat, content will come out, and then you might have problem, aspirate or what. And then clear liquid 3 hours before. If you should not have more, if you have clear liquid, not more than 3 hours before. If a high risk of aspiration, then you have to NPO longer. They can give medication to minimize the risk. Start IV on the left-hand side. And because sometimes they were looking for persistent left superior care syndrome, you could inject the contrast, anything, you go to left arm, okay? So 4% of population have persistent left superior vena cava syndrome. This is the room, okay? The way we have a monitor here. Sometimes it's echo room. We do the stress test, stress echo. So with this room that we can do the TE. So this is your machine, okay? Patient lying here, and you have the equipment, CPR, cart nearby, oxygen source, suction, everything. This is a pattern of room, but in OR will be a bit different. So sedation monitoring, there are different class of the sedative patient, class 1, class 2, class 1 healthy, or up to the severe systemic disease. So we have to know what type of patient, what sort of patient we're involved. And the sedation score, whether they're okay, move for extremities, they're very alert. Their respiration, any problems, circulation, how's about pressure, conscious, oxygen set, okay? So this is just some guidelines for you to follow. And medication that use, if we're going to give IV sedation, then we can give a Domicum, or we have to have a reversal medication nearby. If we give fentanyl, then we have naloxone nearby, okay? And mostly we use silocaine viscous, and then some spray to spray the throat, numb that area before we put, and we check whether there's a gag reflex still there. Make sure gag reflex gone before we insert the probe. Too much sedation is problem too. Then you can get overdose. Then they will get a nausea, vomiting, especially those who had a heart failure or liver disease, and then can get into toxic methemoglobin anemia. Okay, so too little is not working. Too much will be toxic. So everything has to be just right. And test by suppression, gag reflex. So methemoglobin anemia, then the blood look dark, symptom patient get dyspnea, tachycardia, the drop in oxygen sat, and then chocolate bowel, blood, increase methemoglobin, treatment, give high oxygen, and then give methylene blue. Just a precaution that you need to understand about this condition if we overuse the silocaine. And throughout the procedure, we monitor the patient with the oxygen set, blood pressure, heart rhythm, EKG, okay, and suction as needed. Post-procedure, after procedure done, then we check the blood pressure, monitor for about an hour, and patient should not eat till the numb medication effect subsided. Otherwise, they can aspirate. And patient should be told to counsel or call doctor if they still have dysphagia or pain more than 1 day after that. Okay, they should not. Okay, that's the general preparation. Now we look at the probe. Too bad I cannot bring the probe and the mannequin to let you try. Otherwise, afternoon will be a good time to try to insert the probe to look at the real thing, because you'll be sleepy after the big lunch. Huh? What you have for lunch? Good food? Look like the eyes start to drop. So everyone will know. It will be good if we have a mannequin to work on. Too bad that it's too far. Cannot bring the machine. That mannequin 5 million baht. And it's big too. Okay, the probe, usual probe is a temperature sensitive because we put in the through our body had a heat already. Some patients, they have IE, infective endocarditis. We want to look at the IE evaluate stage. They already had high fever, the temperature will go up high. So automatically probe header, it was set to temperature set 41 degree. When the probe is reach 41 degree, it will warn. It have auto cool imminent. Okay, so you look at there will warning sign on the screen. But if the doctor keep doing, sometimes doctor was for focus doing the procedure, patient move around, patient won't cooperate if they try to do it, and they're not looking for technician. We are looking at all this, as I say, we work as a team. You monitor the vital sign, look at the patient or BP, whatever not good, you need to alarm the doctor. So if the temperature go 41, the doctor didn't say, can still keep working on that. It'll go up to 42.5, then the machine freeze. Because it don't want the temperature to go up further, or automatically will freeze. And then you get panic. So at least you know why the system freeze unconditionally. Okay. So if it freeze, then you try to maybe you stop with freeze for a while, and then when the temperature coming down, then it will work again. So you make sure that no damage done to the patient. Okay. So when the temperature up, what should we do? For me, when the temperature up, what I do, just freeze. Let the machine cool down. That's the best way. Otherwise, you can do and whatever maneuver to decrease using of the power of the machine, decreasing the gain, decreasing the depth, decreasing the pulse, PW mode use, decrease the pulse repetitive frequency. All this to decrease usage, so the energy will be lower. But as I say, easiest way, freeze it for 5 days, and then let the temperature down before we go further. So now we need to know how the terminology about the probe manipulation. So if the probe like this in neutral position, okay? So if you retroflex, retroflex, anti-flex, okay, that's a way to have a knob. The big knob will be retroflex. When you big knob turn counterclockwise to retroflex, and then clockwise will be anti-flex, okay? And then if you pull back, call withdraw. If you go down further, call advance or insert. And the probe, it's just like here, you can turn clockwise. There's a transducer here, clockwise or counterclockwise, or turn left, turn right, okay? So to look at the different angle of the heart. Anti-flex, yeah. Anti-flex to go this way, little flex up, okay? And then insert, advance, and withdraw. And then the different, you can see there's another knob that you can change the plane and change the plane of the transducer. 0 degree is right here, straight. And then when you turn, turn the angle. You see over here, 45 degrees from here, 45 degree, 90 degree. So that will give you the different angle of the heart. Okay. Again, this is a advanced withdrawal. Turn to the right, turn to the left or clockwise and counterclockwise. Anti-flex and retroflex. Flex to the right and flex to the left. Okay. Same thing, just a different terminology. And then the plane, as I mentioned earlier, start with 0 degree. So you rotate the angle, you get the angle, get a different plane. So when you forward the probe should not be flexed too much because then you'll be problem. You can advance further by knob. It'll be problem. So if it's become a knob, what they have to push down. Try to release. Try to not lock. Usually our esophagus will let the probe move down nicely. So no lock. Okay. Let the patient lie on the side. You start intubate or put the probe in. So basic position, we go there for position, upper esophageal. Okay, when the probe going down from esophagus, upper esophageal, it's about, there'll be a marker on the probe. See how far you're coming down. So it's about 24 to 28 centimeter. So mid esophagus, it's about 29 to 35. And transgastric, when you go down to the stomach, about 35 to 37. And deep transgastric is about 48 to 45, 38 to 45 centimeter. Okay, so there'll be a mark that let you know how far advanced your probe is in. Because when the doctor put in, at first you have to get through the gap. The patient, when you put in, the patient cough, and once cough, you get a catch and advance the probe in. Then you have to look how far advanced you're in because they'll tell you whether either look at the image or look at the scale on your probe, whether how far advanced you're in now. Okay, this is a plane that we are talking about. You adjust the plane. American Society Echo give 28 views. Okay, recommend 28 views. So we'll go view by view to see. Okay, these are all it's in the all put together. There'll be 28 view, and then you can focus. If you want to look at the mitral valve, you might have a special rotation, special view. If aortic valve, there might be something more, and you can go into the 3D. Okay. So let's see. We'll look at the mid-esophageal view. Okay. Mid-esophageal view is over here. So many different views. When you put the probe in, okay, so you go back, it's mid-esophageal, how many centimeter? About 29 to 35. So you go, when you go like then, and then you're 0 degree. This is what it is. Your probe is here at the mid-esophagus. The plane is 0 degree. You're not tilting, okay? So you get the 5-chamber view. This is like your thoracic 5-chamber view, is that right? Look the same. Because when you say 5-chamber view, mean that there's a LV outflow, left atrium, left ventricle, right ventricle, right atrium. Okay. So there's a mix of esophagus. So you can look at the LV outflow, mitral valve, right and left ventricle, and the tricuspid valve. This is what you see in this case. What do you see in this case? Let's see how to get some attention because otherwise you'll fall to sleep as well as me. Yeah, how bad?
มันเทอร์บูเลนต์ใช่ค่ะไม่อะไรนะคะ
Okay, so this is a view that you put the color. This is 5-chamber view. So if from 5-chamber view you advance further, what is this view now? Now what is this view now? You don't do anything, just advance now further. Then you get the 4-chamber view, is that right? Huh? The aorta is gone. Now just 4, right, left, is that right? So what you see the LV pumping, LV function, RV function, is that right? And if you put color, you have the mitral recurve too, okay? If there VSD, you can see over here too, but okay. So now they turn this to what? Mitral commissurotomy, commissure view. Yeah. So go about 60 degrees. They want to see a mitral commissure, okay? So you get to here. So you just turn the plane. You're still at the 4-chamber view, but you turn the plane to look at the mitral valve at different area, different segment of mitral valve. Okay, this is it, huh? So you can see that this anterior, this posterior, because you turn that to about 45 degrees, so some mitral regurgitation here. You can see that. Okay, LV pumping. So you look at the mitral valve, different angle. This one look like there's a bowing of the mitral leaflet, the mitral valve prolapse a little, huh? And then you go further. You just change the plane to 90 degree or 100 degree, okay, to the 2-chamber view, to look at the anterior and inferior wall of the mitral valve, and of the LV and then mitral valve at a different angle. And then go further to just change the plane to 120 degrees, then become a 3-chamber view or long axis view like the thoracic. So you can see the root better, see the valve better, you see? You see the aortic valve better the way, you know? And then MR, and then AR. Earlier we see tiny MR, you can see AR now nicely, you can evaluate nicely. And LV function, and then the RV. And if there VSD, sometimes you can see VSD go through here, you see? But this one, no chant, no blood running from left to right ventricle, so there's no VSD. And then if you pull back a little more, okay, to look, you pull back, then you see the root better. Okay, if you want to evaluate the root, if there's dissection or something like that, you can, that view at the 3-chamber view earlier, you pull up a little bit, then you see the root better. Here it is. And you can see there's a little plaque here in the root. Aortic valve looks fine, okay? And go back further to ascending. If you pull up further, you'll see ascending aorta more. And then this is the right pulmonary artery. Just by pulling back, you don't have to change anything at all. And now we change the area. From there, you can decrease the plane, and you can look at the PA to look at the pulmonary artery. This is aorta, the one we saw earlier. The previous one is the long, yao. Then we change the plane, become 20 degrees. So this become, from the long, become a short circular. And pulmonary artery become a long one. So you can look at the pulmonary artery on the right branch. If you want to look at the pulmonary embolism, look at the clot. Okay, this is by manipulation, you see, you move up aorta here. Right now, look at pulmonary artery, and then right and left pulmonary trunk. If you want to look at clot, you can see from this view. See, if there's pulmonary embolism blood clot, if there's blood clot here, then there's a way to evaluate. And then if you go further to the decrease of this one, you go further, then you can see the pulmonary vein coming into the left atrium. Okay. This is all the view. And then if you turn to 90 degrees, turn to the left, then you can see over there, earlier is a right pulmonary vein. Now you can see the left pulmonary vein. Okay. And then you can get the PW Doppler to get the This is left atrial appendage, and then pulmonic vein. You can get the waveform. Okay, so you can tell this is a pulmonic vein waveform S wave, D wave, A reversal. This is A by the EKG, you see, and then S, A, S. This is a left atrial appendage activities. And look at left atrial appendage, and then the pulmonic vein, left upper pulmonic vein by the image like this, while your probe is here. So you're looking for clot. People come with stroke, or people come with stroke, and look at whether there's any clot form in the left atrial appendage. And you measure the size of the left atrial appendage, and then they put the device, if they have a clot. You see, this is a device, umbrella or watchman to close the space, so don't let the clot form, okay? So prevent from having clot in some patient, they cannot take anticoagulation, a problem. Okay, now from that view, we still at the mid-esophageal view, just changing the plane. Changing the plane to 25 to 45 degrees, we can see the aorta, short axis, just like in the thoracic. Aorta, just reverse, aorta, and this is a RV outflow, pulmonary artery, pulmonic valve right here. Here it is, you see? Then you can see the aortic valve nicely. It's different from thoracic. If thoracic, RVOT will be here, is that right? But this is reversed because we look from the back. So you can tell this is your esophagus here, and the transducer plane coming up here. So this is anterior, this is a chest wall. So from the chest wall down, you can see RV, tricuspid valve, pulmonic valve, left atrial appendage. You can see from time to time that aortic valve. We can see that there's a trileaflet, not bicuspid valve. This is a tricuspid valve. Okay, and then the interatrial septum. And then we know the cusp. You know the cusp that at the aortic valve there are three cusps. The one that come along at the interatrial septum is a non-coronary cusp. Okay, the one near the right ventricle is a right cusp, and this one near the left atrium is, and then the opening of the left main is the left cusp. So you can name the different cusps of the aorta nicely. Okay, you can, from now you can tell. Oh, we just take the picture. Just, oh, this is interatrial septum. This is non-cusp, non-coronary cusp. This right ventricle. This is right cusp. Okay. So from this view, then you can, if you turn the plane more to 60 degrees, you can see the pulmonary artery better. If you want to see the valve, pulmonic valve better, and go up a little bit, turn to the right. Your probe turn to the right, then you can see the bicameral tricuspid valve. You can see tricuspid valve here. This is a left atrium, right atrium. See, you can see the left. You can get the planes right here. Then you can get the TR. Then you can measure the tricuspid pressure gradient, calculate into pulmonary artery pressure. Okay, you ever do that with your thoracic? Yeah, that's the same way, but this will come, we look from the back. Okay, this, so the plane will be parallel to the flow. So you get a good waveform for the CW Doppler. And if you turn to 90 degrees, then you have a bicameral view. This is SVC, this is IVC, left atrium, right atrial appendage. Okay, so you want to look for any ASD or anything. This is a good view. Okay, now the structure you see. Okay, what is this one? What is it? Let's say from the back. From the back, the first row in the back, the lady first row in the back. What is this structure? เสื้อเหลืองว่าไงคะหนูล่ะค่ะ First one in the back แถวแรกที่หลังสุดเลย อ๋อไม่ใช่เสื้อเหลืองสิเสื้อดำโอเค what's that RA right atrium ใช่ไหมโอเค how about this one คนถัดไปคนถัดมา this one เมื่อกี้นี้ left atrium นะ left atrium sorry did I say right that's left atrium and then here is the right atrium good how about this one no this is a bicameral view so this is SVC superior vena cava you see look at the thing this mannequin heart you see we look at here this is SVC coming down you see IVC SVC and then we look at here in the right atrium okay so SVC here is the IVC okay and this is the right atrial appendage okay and there's the interatrial septum okay let's go further so when we get the bicameral view that's a view we call bicameral view it'll be an exam okay do look at that and remember it's SVC it's IVC left atrium right atrium okay for structure you should know so if there's an ASD then you will see a hole okay in the interatrial septum you'll see a hole and the blood will come from left atrium to right atrium if the ASD. So sometimes we do the contrast, we bubble saline contrast. If there's no hole, we inject contrast in the arm, it'll go to the SVC, is that right? And then it fill the right atrium. The contrast, you see bubble, you then make the right atrium dense, but there's no bubble cross to the left atrium, so this one had no shunt. How about this one? This one there's, you see the dot here? See that? The bubble from the right side cross to the left. So there is a shunt, okay? So that's how we do the contrast injection. Okay, to tell whether there's a shunt, this patient have PFO, patent formant valve, when this drain, the bubble come from right to left, okay? Again, you see that? Left atrium, right atrium. SVC, this structure is a vista terminalis, and this one is a Eustachian valve. This is IVC, okay? And if from this view we push forward the probe down further, the IVC over here, we can see the hepatic vein. Okay, just a manipulation of the probe in and out. So there's a mid-esophageal view, okay? If we push the probe down further, then will be transgastric view, okay? And if we push down further, will be a deep transgastric view. So we start from upper esophageal view to mid-esophageal view. You see upper esophageal view is 0 degree, to see like that. Mid and transgastric, you see the probe right here, but it will cross the LV. This is a transgastric view. Okay, you go down to the gastric, the stomach, then the picture will be like this. Become the left ventricle. And then if you push further, you'll see a papillary muscle or the left ventricle. Left ventricle becomes circular, become a cross short axis view. And if you push further, you can reach to the apex of the left ventricle. And then just that, for example, this is left ventricle, right ventricle. In this case, you can see what? The color coming from the left ventricle go to the right ventricle. You see, it's a very back, which thoracic you may not see. This is a VSD from MI. You see, there's a rupture ventricle septum going cross over here. Okay. So there's a transgastric, and then if you change the angle earlier, it's 0 degree. If you make it to 120 degree, it'll be long. So it'll be a different view. Or if you push down further to deep transgastric, the plane going to be like this at 0 degree. You'll be like 5-chamber view here. You see, from here the LV, aorta, 5-chamber view. Okay, And then this patient have the TAVA, you know TAVA? Transcutaneous aortic valve replacement by putting the valve through the catheter, okay? And this is a valve, and then there's a leaking, there's a power valve leaking. And then you can measure the pressure after the valve replacement. And this is LV and aorta, okay? This is the deep transcatheter view. And then if you turn deep transcatheter view, you turn or decrease the angle, then you can look at the right side. You can see the RV. And then look also, if you turn around, you can look at the interdial septum. Okay. And if you pull back, you can look at the aortic. You see, this is all the manipulation of the probe. And if you pull back to the upper esophagus, you can see the aorta in the aortic arch, okay? And you turn around, change angle, you'll be aortic arch down, right here, okay? And then pulmonary artery. It's a lot of, if you have a mannequin, it will be easier. But the way this just gives you some general idea how things are. And then you back to the pulmonary artery, right and left that we did earlier. And then if you turn your catheter to the back, then you see you see? Right, and initially your catheter to the front. Now you counterclockwise, go to the back. Then you can see the aorta here, descending aorta, the circular area. So look where there's any dissection. And you can change the angle to 90 degrees. From the short, it become long, descending aorta. Okay, that's all the 28 view. We done. We are done. Fast? Okay, we'll give you a break. And we'll look at each valve. 5 minutes. ไม่ต้องจำเพราะต้องทำอันนี้ยากให้รู้ว่ามันหมุนยังไงช่วยยังไงไม่ต้องจำอะไรนะคะ No because it's just let's see the angle will be difficult. It will be difficult because you never do it, so difficult. But at least you look at the picture, you know what structure it is. Manipulation, that's another section that you need to learn, because each patient is different, the anatomy is different. So you need to know by looking at the picture, you know what structure. Just like I say bicameral view. Where's the SVC? Where's the IVC? Yeah, let me show you. Yeah. Just like this, then you should know. This is a bicameral view, because you see the SVC, you see IVC, interdial septum. Then you should know the structure, left atrium, right atrium, and this is the Eustachian. And sometimes they have Curie network. Okay. Yeah, this is a bicameral view. Okay. So 5 minutes break then. Okay, so we can continue. I don't expect you to know the view because even the doctor who do it is difficult. And then you didn't even have experience with the mannequins. So I expect you to know the structure. You don't know, you don't know, you don't need to memorize the view. Useless. The doctor who do it. But as a team, you are in the team, technician, the team. You need to know contraindication, absolute relative contraindication when not to do it. Is that right? You need to know the indication when to do it. Is that right? Something as a team member of the TE, you're a technician. You need to know when to warn the doctor. You need to know when is the problem. If you know the contraindication, then you know that patient should not come in to do the test. Okay? And if patient has problem, what type of problem they have? Okay, so as a team, you look together. You need to know when you look at the picture. Let's say the problem, you need to know. When the doctor do the procedure, you look along, and you know, oh, what structure, and suddenly why they panic? What's going on? You do the picture, you don't know. There's a problem. So you need to recognize the structure. Okay, so you don't need to memorize the view. No way you will remember that those even doctor who do it because each patient anatomy different too. Okay, don't get too serious on that. Okay, all right. Now, any question you have so far with the view? Let's say if the aortic valve cross section, you see 3 cuts. You know that's normal. Can you tell which cut is which? That's quite advanced. If you can tell, you're good. You're very good. Some doctor cannot tell whether that's a right cut, left cut, non-coronary cut. Can you tell? No. I don't expect you to know, but it will be great if you know. Let me go back to that picture. And I think we'll see some more of aortic valve later. It's okay. Just like this, you know, the structure. If I label, say, okay, what is this? Can you tell what is that? What is it? LA, is that right? Left atrium. You know where's the front, where's the back. This is the transducer, so this is the esophagus. Because our transducer put here, and then this is the plane. So this is the anterior, this is the posterior. That's where our probe, you see? Do you understand that? The picture coming, your plane coming out here. So this is left atrium, this is the right atrium. This is interatrial septum. This aortic valve, is that right? This is left atrial appendage coming from time to time. You can look here. And this is your right atrium tricuspid valve, RV, outflow, pulmonic valve, pulmonary artery. Can you tell? This is something I expect you to know. Okay, it's like thoracic, but just different. Hand thoracic, you go from anterior to posterior. This from posterior to anterior. If hand thoracic, your right ventricle will be up here. Is that right? So if you know more, this is more advanced. Aortic valve 3 cuts. This is interarterial septum. The cuts that go with interarterial septum is non-coronary cuts. The cuts that go with the right ventricle is right cuts. The cuts that go with the left atrium or left main, the coronary artery come up here, is a left cut. If you know like that, you are perfect. You are 100%. Okay? Difficult? No. And then the view that might be difficult for you. This one, okay? Right atrium, right ventricle. This tricuspid valve. Okay? If you point it, then you can tell. If you can tell the anatomy, you're very good. This view, bicameral view. Mid-esophageal bicameral view. You can see the bicameral mean that you see SVC and IVC. This is your left atrium. This is the right atrium. Crista terminalis, right atrial appendage. That's it. If you can tell this, that's good enough. That is quite good. Even doctor might not be able to tell, but you see the structure that you need to recognize. Okay, now we're going to the mitral valve. Okay, mitral valve. So we need to understand the anatomy. What's the nearby structure? This is the almost like 3D, or this is in fact, is from the mannequin. We look at the surgical view, okay? This aorta, pulmonary artery, left atrial appendage, mitral valve, anterior mitral leaflet, posterior mitral leaflet, right side tricuspid valve. If we put that a surgical view, okay? And this is a commissure open well, all right? So what we look at the leaflet, mitral valve, we look at the leaflet mobility, whether it's open well, closed well. We look at the coaptation of the anterior posterior leaflet. Usually there'll be 8 to 10 millimeter coaptation of the leaflet. Yes. ขอโทษทีนี้ aorta นะนี่ pulmonary artery. Okay. And this is the left atrial appendage. Okay. So left atrial appendage is in fact on the lateral. Is that right? This is medial. This is the right ventricle, right atrium, and then the tricuspid valve. Okay. So you look for coaptation. You look at the nearby structure that you need to understand. Okay. What we are all talking about this. Okay. Aorta, mitral valve curtain, or this type of thing. That's more advanced. So with the short axis view, we look at the mitral valve, as we just say that. So appendage is a lateral. Okay, when you see left atrial appendage, you know that's a lateral anterior lateral. So we give a number 1. This mitral valve near the lateral anterior got A1, posterior got P1, commissure got C1. Okay, whatever near the lateral, you give number 1. Medial number 3. Okay, so 1, 2, 3, 1, 2, 3. For posterior leaflet, you can see the 3 indentation. You can make it a more distinct 3 segment. And here it's hard to tell. I'm going back to can see. Okay, when they move. See, you can see A1, P1, P2, P3. So correspond with that A1, A2, A3. Okay. So same, this is a label, say, anterior leaflet. So wherever the appendage is, so A1, A2, A3, P1, P2, P3 correspond with that. C is a commissure. Anterior lateral commissure is C1. Posterior medial commissure C2. Okay. So that's it for segmentation of mitral valve. So when we talk about segmentation, we understand all this aorta, like appendage one or go with the appendage. Then when we do the angle, you know, when we turn the angle, when you were talking about that, normally when you get 4-chamber view, that's 0 degree. This is a 4-chamber view. So it will tell you which segment of the mitral valve this plane is. Say, here, you can look at this, this is a anterior leaflet, posterior leaflet, A2, A3, P2, P1 by, look at this, the way it cut, the plane cut through. It cannot be exactly, this is give you some rough idea because each anatomy, the heart tilt differently. So it will tell you roughly that this is about A1, A2 or P1, P2. When you cut through there. When you go to the 45 degrees from here, the plane, you see, you turn the knob, the plane to 45 degrees, become this one. Depend on it going up here or 45 degrees down here. You see, you understand? If the plane going through here, it will be A1, A2, A3. See, A1, A2, A3. Or if the plane, if it plane come up here, to cut through here, it become P1, P2, P3. So you can't just memorize it. That's why I expect you to know. Even me, sometimes confusing, and then have to look at get into 3D picture to make sure I'm at the right, exactly the same thing. And then we turn to 90 degree, become a 2-chamber view. Okay, you start from 4-chamber, 2-chamber view, 90 degree anterior and posterior. Then over here, you see, it go to A2, A3, P3, you see, and go 3-chamber view. When you go through aorta, 3-chamber view is easy view because you have aorta help you. Then you know this plane have to go past the aorta and then A2, P2. Okay, and then they'll go to commercial view. So this when you evaluate mitral valve, they get to the plane 0 degree, and then you just turn the knob, turn the angle, advance angle, so you can get into different, just like you from 0, and then you turn this one. You look at the mitral valve at the different segment by turning the knob with this type of plane. Okay, understand that? If not, we're not going further till you understand it. This is hard, but it's once you get it, you get it. So all this not exact thing that you have to memorize, but just give you idea why. When we get to the 0 degree, then why we have to evaluate all the mitral valve as a whole. Then we turn the knob around to look at the different segment of the mitral valve. Okay. Here are the things. Okay, they just give you this is a biplane, so just give you what I just tell you, and the number won't be exactly the same. The only one that is quite accurate is a 3-chamber view. Usually is a 3-chamber view. Then you get the aorta, then you get the A2, P2 because you go through here. Okay. Okay. So next is the aorta, aortic view. When you look at aorta, if you look at descending aorta, it's quite easy. Your tube is here. Aorta is in the back. So you just turn the tube, turn your transducer to the back. 0 degree cut through, then you see the aorta is cross section, circular. If you want to see aorta long, you just change the plane from 0 degree to 90 degree. It's perpendicular to 0 degrees, 90 degree. Then you see the aorta as a long. See that? So you see descending aorta, short axis, long axis. Then if you pull it up further, withdraw it, then you're going to, from the descending aorta as a circular, become almost like an arc. It becomes slant now because it starts to curve. Then you can see the curve. And then if you want to go to the front or change the angle from this curve down, then you will see the arch and pulmonary artery. You see that? The aorta. You change the plane to 90 and you see this pulmonary artery. So these are the manipulation that no need to memorize, but you need to know how it, because as I said, each individual is different. For example, here you can see what descending aorta, okay, at 0 degree, and you can see plaque, and then we make it to 90 degree, it become a long axis, and I want to focus on here, then you can see the plaque right here at the descending aorta, okay? So that's all for aorta and 2D. We are talking about 2D echo. So at times 2D just give you that plane. We don't perceive the real thing. Sometimes there's something behind that plane, or just a little bit turn, you get another plane. So we go to 3D, then you get more depth, then you see more. So how do we do from 2D to 3D? For example, aortic valve, okay? This is the plane that I go through in the short axis view, and this is a long axis view. So we crop, we add this, and this is the thickness. This is on this way, okay? On the this, let's say this XY, this might be XZ. You see the axis, different axis. We add these two together. Crop. I want to add this one. I want to add this one. The equipment will generate the picture put together with the depth. You know, this is this plane, and this is another exact plane, or with the depth. So we get to the volume of the aorta, and then we flip over, then you see aortic valve. Okay. For instance, we just talked about, I told you already, non-chronicus, right chronicus, left chronicus. Okay. So with this is important for when nowadays with the device you measure the size of the valve, the size of the device to put from this TE by doing all this. Okay, we can get different plane, annulus, how big it is, the sinus valsalva, the sinotubular junction. We can get all these different location, get in different sizing of the aorta, and get the correlation of the aortic valve and this, okay? Same thing with the mitral valve. We crop here, crop the depth, and then we get the turnaround. This is just the way to do it. Nothing serious. You don't need to. Don't need to know because you didn't have a hand-on machine, but you need to know that how they do it, and it's available that now. In fact, available for a long time. For example, you get this, crop this, you can see what this aorta, is that right? And then this anterior mitral valve, posterior mitral valve. So there's some lesion here. In the this is a surgical view, left atrial appendage. So A1, P1. So this is P2. Is that right? Is that right? P1, P2, P3. So there's a what? There's a lesion in P2, whether it's a flail and prolapsing of this segment. See that? So you can tell exactly where the problem. So the surgeon going to do the surgery. They're going to trim this, cut this, and sew this together or whatever. So you at least you can identify and tell exactly where's the lesion, what segment of the mitral valve. Same thing like this, aorta, anterior mitral valve. But what's the difference on this mitral valve? The mitral valve is so small. The restriction of opening and closing, is that right? Yeah, looking, this is like a fish mouth appearance. The fusion of the commissure, the calcification here. This is severe mitral stenosis. Left atrial is big. The tricuspid valve still good. You got tricuspid valve open nicely. Okay, so this is the beauty of the technology that gives you all the information. So there are protocol how to crop the right ventricle, left ventricle, interatrial septum, aortic valve, mitral valve, pulmonic valve. All this is there. Just know that. So for example, this one. What view is this? Bicameral view, because you look at the SVC and IVC, is that right? And then what you see is the gap, is that right, of the interatrial septum. Huh? So what do you call that? ASD. And then you see when you put color, there's a flow away from left atrium to right atrium. So there's a left to right shunt, is that right? Blood flow from left to right shunt. So ASD, you can measure the size. Okay, let's say it's 3 centimeter. This ASD 3 centimeter, but still keep there's a shunt from left to right. Okay, and then when we do the 3D, you can see I can measure. This is the interatrial septum. This is the hole. It's a almost circular hole. Then you can measure and then get the device to close this ASD. Okay? ASD, SVC, IVC, ASD. Okay? How about here? This is interatrial septum, left atrium, right atrium. This is the interatrial septum, patent forming ovary. So during the Valsalva, you can see this is very, we give the bubble saline injection, the bubble go to the left during straining. You see, the patent forming ovary open. This go up, patient come with stroke. We demonstrate the patient had a shunt, open patent forming ovary. So this need to be closed. Okay, they can get a device to close this one. They say interatrial septum, IVC, the 3D. Usually, if you get 2D, you just see this. You don't see that. You don't understand that IVC coming this way. You never imagine that with the plane, different plane, you can see the tricuspid valve is here. This is your IVC come here, and then your coronary sinus come open over here, aortic valve. All this, you see aortic, the tricuspid valve, how it go, how the coronary sinus open. Just like you learn anatomy, but learn from echo. And then this will make you love anatomy class. And looking back, oh, I should pay more attention during the gross anatomy. Do you have to go to anatomy class? No? Yes. Do with the Ajahn, the cadaver. So you want to go back again now? You understand what you look for. During the time, not you still dissect with the care, but now you know what you want to look. Whereas coronary sinus, how the coronary sinus open from the tricuspid valve. What's the relation of the coronary sinus to tricuspid valve? If you know clinical, when you go back there, it is more worthwhile for you to understand how they put a pacemaker, biventricular pacemaker. How do they do cardiac resynchronization by put pacemaker in the coronary sinus? What's the principle behind that? You see, all this, it will be good to go back. In fact, they should have a little bit of anatomy early year. And then before you graduate, go back to anatomy, another section. You gain more. You know what you should learn and should look for. At that time, you're still so innocent, blank. You go through, just don't know what you're looking there, assign you to do anatomy. But now if you go back, you know, oh, I want to look where's SVC open, where's IVC open, all this type of thing. What's the relationship to the mitral valve, okay? Okay, what's the clinical application TE? Now the hot issue. Years ago, TE mainly to look at the structure that cannot be seen nicely by thoracic, like the pacemaker, IE pacemaker. We look at the pacemaker from the thoracic, cannot see well. You want to see any blood catch on the pacemaker, IE on the pacemaker, or you want to see the complication of IE to the causing aortic root abscess or not, okay? Now how it guides the transcatheter procedure. So you know, first thing for the transcatheter procedure, you need to puncture the interatrial septum, called transeptal puncture, to put the catheter through. What procedure are there? What is this one? Okay, just look at the picture. Okay, the first one, first row, last person. What's A? By guess. What's the procedure? Transcatheter procedure. Mitral valve ทำอะไร PTMC balloon mitral valve. How they do that? By this picture, you explain to me how they do that. Put catheter from the vein, huh? Femoral vein, very good. Go through to right atrium, and then how they go to the left atrium? Transcatheter puncture, okay? And then put the balloon and open the mitral valve, PTMC, is that right? How about second one? The next one. And there's a clip for severe mitral recur, mitral clip, called the valve flail or whatever. So the clip make the recur less. Number C, what's that? Stent for the mitral valve replacement. Huh? Stent put a new mitral valve by this, by going through same thing, huh? To the transeptal. How about this one? Quite similar, they're different stent, huh? How about this one? E. What's the E? The next person? There's a mechanical valve, but there's a leak. The mechanical valve have problem. Paravalve leak. So they put the catheter to and they put the plug, close the leak. Paravalve leak, okay? So go through transeptal too, is that right? How about this one? Oh, very good. Who teach you that? อาจารย์ EP ชื่ออะไรคะที่ไหนจำพลเหรอจากไหนจำพลจากไหนเลยโอเคแจ๋วแหววนะใช้ได้เลยแสดงว่าได้ภาพพจน์แล้วนี่ล่ะไม่รู้นี่อะไรก็ไม่รู้นะก็คือเอาอันนี้ดีกว่า H what's H cross appendage a watchman ใช่ไหม the device cross appendage so you see all this need transeptal so TE come into role so it help to get to locate where you're going to puncture okay so time like this is the balloon mitral valve 1984 you born yet เกิดหรือยัง and pulmonic vein isolation 1998 we talk about history left atrial appendage 2003 per Q deviceเนี่ยนี่ mitral valve replacement mitral valve in valve okay and then transcript mitral crypt 2008 and paravalve leak close it 2006 all these are timeline of all this technology that have evolving so we put the catheter to we guide them how to poke through the interarterial septum, okay? And then we navigate them during the time if it's a difficult case, and then look for complication post-procedure. So you can see again, this is your bicameral view. That's how we cut the plane. Now you can imagine, you don't need to go to anatomy lab now. I show you here, HVC, IVC, and your foramen ovalis somewhere here. Okay, so you go through here, there's a thinness area. So you can we can guide them either by T or ICE or intracardiac echo. So it will help you to go through. You see? SVC, IVC, this is the area the interventionist can put the catheter at the location right. Okay, bicameral view. You look through here. If for the short axis view, that will be anterior and posterior. So with the IVC, my bicameral view, there's a superior and inferior. Is that right? So you want to put the catheter in the more pointing to more posterior, not to anterior, because to anterior, then when they poke through, it might puncture the aorta. So I want to point to the more posterior, okay? So we guide them, give them the location, say, you poke here, okay? You put the, so they do it. They had the, put the catheter from IVC, go to SVC, and then drop the catheter down. You can see where when it go into the septum, it's causing a little bit tenting. So right now, the catheter right here. So you get a good position, okay? Confirmed by short axis and by Bicameral View. So at the junction SVC, right atrium pull down to from the SVC. After that, then dilator going there, and then at the limbus formant ovale, tenting more of the ovale, and then when you get the ideal position, needle will tent here and push through. Okay, so this is the way it is when it go through. Okay, some of them are very stiff, tenting, puncture, and crossing. Okay. So after that, you need to make sure no complication. Sometimes you can get the cardiac perforation, can get blood clot, get air emboli, get autogenic septal. See what happened with this one. Next person. Tell me complication. Still a Bicameral View, huh? But 3D. What do you see? You don't need to do it, but you can help. Tell them because you are the team. I don't expect you to do it, okay? T9, where? You see clot. Mobile clot, where? Where? This is left atrium, right atrium. So it might coming from the we know IVC, and then it's around here. It's flying around. Yeah, and then besides that, it's into atrial septum. It's going to go to this one go loose, go to the brain. See? Okay, so you once you see this, you should tell them clot. Okay, you are the team. Okay, so alarm them so they will stop, give anticoagulation. Okay, and then might suction, get the clot out. This is what they suck out, blood clot. Or even air emboli. You see, when there's another complication that can happen. And after procedure of the transcatheter, what happened? You have a ASD, is that right? Left to right shunt form. Iatrogenic, we do it, not natural ASD. Iatrogenic ASD. So with this, we'll have to understand all the information here. I'll explain this to you already. So besides that, with the TE, we can see whether the mitral valve is primary disease, degenerative by prolapse or flail, or this is a MR from functional mitral regurgitation. By look at the valve, mitral valve, we have to get all the measurement, okay? So no coaptation, posterior leaflet, tenting high, all this, and measure it, and explain, label, interpret the way the leaflet morphology, the leaflet motility, caudal annular size. See the valve movement, this is no good, huh? The coaptation not together. This is the tip go up with the almost the body of the leaflet. This is all this with the explanation. So we have to by TE you can explain or describe more. So the surgeon will know whether the patient, just like this one, you can see there's a flail leaflet, right? There's edge, the mitral valve, the edge of the mitral valve point to the left atrium, and there's no coaptation, okay? causing severe mitral regurgitation here. So you give a degree of regurgitation or jet which way it go, and you give the pre-surgical evaluation, the valve anatomy, MS pressure gradient, all this, and then the nearby structure, left atrium, PA pressure, TA, tricuspid annulus, LV function, V function, all the involved structure that we need to know for either the surgeon to go for repair, just like this one, the flail P1. This is the appendage, so 1. Flail P1 with severe mitral rigor. So the surgeon will fix this one, and after surgery, you evaluate how well they're fixed. Or this is the annuloplasty ring. You can see all the studio stitch here, then you can see where there's any leaking post-procedure. So with the TE, you can give a detail whether the patient feasible for surgery, valve repair. There's a paper, if anyone interested, you can read when you have free time rather than reading novel or watch what's that? Watch a Korean movie. Read this article. A guideline for using TE assist with surgical decision making in operating room from this one. What's a good movie now? Mr. Sunshine or something. Oh, rather than watch a movie, get that time to read the paper, huh? Or see whether the patient eligible for the mitral transcatheter mitral valve intervention. Okay, then you look through whether the gap, whether regurgitation gap is good enough. If too much, not feasible for this. And then H2H mitral clip. Okay, another paper if you want to read. Okay, Jack 2020, just 2 years ago, and see what ideal echo feature that will fit to do that, and follow up to grade MR by TE and TE after catheter intervention. Very difficult to assess after clip. And with the TE, you look at the morphology. You do, for example, aortic valve. You can see this is severe aortic stenosis, and then how it is, what leaflet involved, whether it's a tri-leaflet or bi-leaflet. Morphology of the aortic valve. Okay, you can see there's a flow turbulence aortic across aortic valve. There's a severe aortic stenosis with a trace AR. Okay, you still remember how we classify which cus is this one? No, this one left, because you see left vein, huh? And this is right. Very good, huh? And then your long axis view. So this is A2 and P2. As I say, that when once passed through the aorta, most likely A2, P2. Huh? So you get a central jet of mitral regurgitation. And what's this? คนที่คุยตอบมาสินี่คืออะไร What's that? What valve is that? What valve is that? Mechanical, yes. What valve? Mitral aortic tricuspid, huh? Mitral valve. Normal? Yes. Why is yes? Because เป็น mechanical valve, so it thickened already, huh? So it moved diastole, it open, systole close nicely. Both leaflet is a bi-leaflet, St. Jude mechanical mitral valve. So it closed, it opened nicely and closed nicely. There's no stuck leaflet. Sometimes the leaflet not moving because of the blood clot, whatever. So this is a normal mechanical valve. Okay, that's it. That's it. Time is it? Oh, I'm done early. Okay, another break. Okay. Okay, any question so far? Any question so far? So TE is clear, huh? All right, so we have some free time. So this is just for fun. Okay, so no pressure. So TE in SD. For SD is if at advanced echo nowadays there's another training, so interventional echo. So they'll have to go another 2 years of cardiology and then 3rd year for interventional cardiology. So mainly to go with the intervention structural heart, treatment for structural heart. So atrial septal defect, we know that there's many areas. So when you get the TE, there are so many plane. See, so if you want to get to this plane, this is the way to get your plane from the TE. So you can see almost the rim and then the defect where it is. Okay, the anteroventricular posterior set superior. That's when you cut through here. The plane is the atrioventricular and posterior superior view. And then if you go through there, then the picture of the 2D you get is like this. Okay, so make you understand why we're talking about when you're doing TE, you turn the knob, change the degree of the angle, or you rotate clockwise, counterclockwise while you get into each plane. 2D, we just get that such a plane. It might be not accurate. So from the 3D, it will portray and give you an idea why you get such a 2D image. And then from that 2D image, how can you identify where it is? So just like here, then you get we were talking about that earlier, posterior, inferior, and anterior with the aorta, with the anterior location. Okay, so when you get the transeptal puncture, then you know you don't want to go anterior because then you can poke into the aorta, causing bleeding. Okay, so you might want to more pointing to posterior. But the same token, if you go too posterior, then you might get into another trouble, get to pericardium. So there's many issues that the person who do the procedure have to know very well. And 3D really helps us about that. This way, your bicameral view, then you get to the superior and inferior. See 5 and 6, inferior, superior. The angle, you see, 0 degree, 90 degree, okay? So this is your ASD. Just like what we were seeing earlier. Posterior superior, atrioventricular, about here. Posterior inferior, anterior, okay, aortic. So they were saying sometimes you cannot get the rim right because the way to put the device, you have to have a edge about 5 millimeters for the device to hold on. So they have to measure all this edge and whether the rim is adequate for the device or not. Here is the inferior, superior. Okay. So TE is also help for finding the source of the embolism, intracardiac, or could be from the clot, from the arrhythmia, from the vegetation, or from tumor. So transthoracic helps somewhat, but still not as good when you have the TE has more benefit in finding this. So what do you see? What structure is this? This is just for fun. So anyone want to try? We have a 2D and we have 3D. I'm sorry. This is a left atrial appendage. mitral valve, and then this is the what they call the Q-tip. So separate the appendage from the pulmonic vein. So this will be left upper pulmonic vein. And the machine now with the echo machine, you have a biplane. So we can make this, let's say this is 40 degree, there will 90 degree perpendicular to this will be this plane. Okay. In fact, the new echo generation, you can change this angle too. So it's quite advanced. So what you see, this is left atrial appendage and left upper pulmonic vein. And now you get the biplane. This plane, just like from here, you open this part this way. So you look at the appendage and your pulmonic veins over here, okay? So what we're looking whether there's any clot or not. Okay, so we have question whether this is clot or not, or this is just artifact, reverberation. How can we be sure? Sometimes very difficult. Is that right? When you have patient come with stroke, you look at that. You cannot be sure this can be clot because if reverberation is here, the size should be here, but this is out. It's not perpendicular, so we are wondering. And we look at the 3D, still not very helpful. This is the pectinate muscle of the left atrial appendage. How about here? Another view. So aortic valve have a turbulence. Huh? This is almost a long axis view. Aortic valve have turbulence across aortic valve. And mitral valve, there's a relative mitral stenosis. Okay, the posterior leaflet is restricted, not moving. So you see the flow conversion here. And when we see this, so there's some degree. When you see turbulence, color flow turbulence across aortic valve, tell us that might be some degree of stenosis of aortic valve. So we look at the cross section. So there's a fusion. You see, this is the non-coronary cusp, right cusp, left cusp. So there's fusion of the right and left cusp. You see that? This two, or is this a bicuspid valve? You see, there's fusion. There's a rare field here. So this patient very likely is a bicuspid aortic valve. Okay, you see, there's a fusion over here, and then they move when they open, become elliptical. Not like before that. You see, you said 3 leaflet. These two fusion. There's a rare field here. So there's a fusion of the right and left cusp, which is quite common for the bicuspid aortic valve. So this is a bicuspid aortic valve with a aortic stenosis. Okay. And another case. What do you see? Another. Look like a clot, huh? Clot here, the appendage. So right here, the 3D show you there's clot there. What's this? Bicameral, very good. Now you are very good, bicameral. So this is the interatrial septum, but interestingly, this is what they call hypertrophy, lipomatous hypertrophy of the interatrial septum. And there's something here. Huh? So this is SVC, this IVC, this left atrium, right atrium. So we put a color. Oh, no color. That's all. That's all what they want to show. Oh. No color. Okay, so maybe they just want to show the lipomatous of interatrial septum. There might be, I don't know, if the patient has some problem, we have to look through here. This is not clear. Usually you see clear when there's something like this, difficult to pinpoint. There could be clot here or not. That's something that to clarify. Okay, that's the same case. So the color now come. What do you see? Look like there's a color go through from the left to right, okay? So could be ASD, okay, small, but that area could be the PFO with ASD. That if we strain, if the flow go, if the patient strain, the flow go to the left atrium, so they have a patient have the hybrid with the PFO with the ASD. There's a hole there, but with this, yeah, because this is a region of there. So this is almost at the edge of the fossa ovary. So have to see whether it's a hybrid or mainly ASD, small ASD. Around that area. Okay. So this can be just a small ASD, or could be hybrid PFO with the PFO with the ASD. As I say, we have to strain and see whether the flow go back. Some people they have combination. Okay. Do they give a? They did not do the. This is the same one, and this is a flow from the IVC. And show the flow left to right shunt. Now we bubble, okay? You see anything? You see any bubble? Can you see bubble close? No. Here, you look again. You see? Initial when they strain, you see? So if it's a hybrid PFO with ASD, you see the bubble? One, two, they have a strain. Yeah, you see that? Like, you see? See that? Catch it? When they do the bubble and then strain, the bubble come from right to left. So there's a PFO. And then with the color flow, the left to right. So it's a hybrid. The patient has both. Okay, you see the bubble going across from right atrium to right to left atrium. Yeah. Yeah, I see. How can I visit? I don't know whether I can. Cannot control it. From here, cannot control. So this one, this patient, you look, this one is the descending aorta. You see the plaque? How thick is the plaque? Patient had aortic plaque. This is aorta. Okay, you look at the plaque. And we get the biplane, this is a cross section 0 degree and 90 degree. You see how thick is the plaque? Oh. Okay. See, protruding in here. Okay. Okay, so aortic sclerotic plaque. So this is quite, the atroma is quite big. And for infective endocarditis, this is helpful for TE, helpful regarding that, to look at the vegetation, to see any abscess, and to see any destructive lesion. Okay, what do you see here? This is a 5-chamber TE. เห็นอะไรจ๊ะ valve ไหนติดเชื้อ which valve? You see that? The aortic valve is thickened and calcified, and there's a structure coming, you see? Yeah, and then there's extra, usually you should not see it, drop into the ventricle, all right? Aortic valve is close like that. So there's there's vegetation or whatever get on the valve, and then it, during diastole, flop down. See that? See that? And there could be PFO too, tiny bit here. Patent worry. Mitral valve so far looks okay. So that causes AR. You see that? Here. This structure, you see? These are all vegetation. These two are vegetation. So thoracic might not see. That's why you need TE to help you identify. These are the vegetation and cause AR. Okay. Cross section. See? Another view. This is a long axis view. And the valve thickens, so there's destruction of the aortic valve. The LV size is okay. The root here, there's just a plaque in here. This is a left atrial appendage. It looks okay. No clot. This tricuspid valve. Tricuspid valve look fine. Okay, look at that. Look at that. Look at that. It's a flail aortic valve. It dropped there with the plaque. Bad AR. And the 3D. See? There's destruction of the aortic valve. The vegetation at the edge of aortic valve. So the echo for IE vegetation is very helpful. It's a echogenic density, and then you see whether there's any abscess or not by look at the echolucency along the root. How about this? How about this? What valve is that? What do you see? Normal, abnormal, abnormal width. Huh? Mitral valve structure normal ไหม What happened? มัน prolapse มีอะไรเกาะไหมช่วง during the time of systole, you see that there's a echo mobile density attached to the posterior mitral leaflet, and เป็นอะไร เป็น vegetation เกาะที่ mitral valve leaflet posterior leaflet เห็นไหมแล้วมันสะบัด ถ้า vegetation for IE usually is on the atrial side for the mitral valve, so it moves. You see, it's so mobile, so labile echo density attached to mitral valve and move into the left atrium, causing also the mitral regurgitation. And mitral regurgitation go to the, usually regurgitation will point, the jet direction will be opposite to the lesion. So the lesion here is a posterior leaflet, so the jet go to anterior. So this is a quite big vegetation on the mitral valve leaflet. Okay? Don't miss it, huh? See? So you measure the vena contractor. And here it is. See how ugly it is? With the 3D. You see how you can measure the size. And if this go loose, go to the brain, the patient will have a stroke. Aortic valve, we talked about that already, huh? Still remember. Non-cusp in the left cusp, right cusp. So this should be an exam, huh? Should be? Okay, you measure the size of aorta. This is a long axis view, okay? So deep transgastric view, the one that we showed you earlier. So it will help us to see the aorta, aortic valve, and what the gradient, the flow, we can measure because the perpendicular to the flow. The again, aortic valve, how we label, how we know which cusp it is. If I show you this, you can tell, huh? No matter how I turn it, you can tell which cusp is which. Is that right? You have confidence? Have confidence. Because this is interatrial septum now. So interatrial septum is a non-cusp, non-coronary cusp. Okay, so we can do the measurement. What's this? Aortic CV, aortic stenosis. This is three leaflet. And this during the time we put the TAVR or percutaneous aortic valve replacement. The catheter going in there. The catheter going in there. And this another case that's very interesting. What do you see here? The long axis view. The turbulence occur below the aortic valve, so there's obstruction before aortic valve. So if you look carefully, you see the turbulence below aortic valve right here. So you look carefully, there's a ridge here. The ridge here, you see that? This is a subaortic membrane causing obstruction. You see? So something the patient born abnormal by the 3D, you can see that. So you cannot see that with the transthoracic. With the TE, that's how it helps you. So mitral valve, as we mentioned earlier, depends on the plane that we cut. Okay. For example, here, we get through the become 5-chamber view. So this will be A1P1. If we move here, become A2P2. See the plane, depend on the plane they cut. If it going here, then you get the coronary sinus. You see? So it's useless to memorize. So is this normal for coronary sinus to be seen here? No. Coronary sinus, this is too big. So this patient has what? Persistent left superior vena cava syndrome. Okay, so the mitral valve, this is how it arranged. And the transgastric, you can also, the transgastric, then you can get from the back. Okay, from the back, this is the front anterior will be 1, medial will be 3. So 1, 2, 3, 1, 2, 3. All this is help you understand why I told you that you don't need to memorize it. It won't help because the plane will change as time go on. Okay, this is a vegetation. Okay, with the mitral regurgitation. With a different plane and different cut, you get to different level, different segment of mitral valve. A2, P2. And here it is. Okay, I think we have enough for it's a long day, many hours. You guys are very good. Aortic dissection. It's too much. Okay. That's good. So good luck with your study. Okay. Bye-bye.